Welcome back. I hope you had a nice break. I am excited to introduce our next speaker. Our next session is an update with AZP-3601, treatment for hypopara. We're happy to introduce to you Chief Medical Officer from Amolyt, Dr. Mark Sumeray. Welcome.
Thanks very much, and thank you for the opportunity to present this update, and good afternoon to everybody. I'm going to share my screen so you can hopefully all see the slides. Let me just make it into a full screen presentation. Okay, so as I said, it's a pleasure to have the chance to give you an update on the progress, exciting progress that's being made by Amolyt Pharmaceuticals with respect to the development of a novel investigational PTH1 receptor agonist for chronic hypoparathyroidism. So first of all, just a few words about the company. You may not be familiar with Amolyt Pharmaceuticals. It's a relatively small private biotech company that has been founded fairly recently, is actually headquartered in France, in Lyon, but also has some presence in Boston, in Massachusetts. And the mission of the company is to transform the lives of patients suffering from rare endocrine and related diseases. And so with that in mind, the company actually has two products in its pipeline. The first one, which I'm going to talk to you about today, is AZP-3601. It's still an early stage investigational peptide drug, which means that it's not yet approved. It's still in clinical trials or clinical development. And hopefully when it gets to the point where it's about to be approved, it'll have a name that's a little bit easier to remember than AZP-3601. And we also have an earlier stage peptide drug in development, also has a name that's a bit hard to remember, AZP-3813, and that's for acromegaly, which is another rare endocrine or hormonal disease. And you can see that the upcoming milestones in this slide for AZP-3601 are a launch of a phase 3 clinical trial in the first half of next year, which is obviously something we're very excited about. And during the course of this presentation, I'm going to tell you about the work that we've done so far, the data that we've generated very recently, actually, in a clinical trial in patients with hypoparathyroidism, and our plans for initiating the next step, which is a so-called pivotal clinical trial, which, as it says, we plan to do in the first half of next year. So, first of all, I won't spend too long on this slide because I know that the audience is probably very familiar with hypoparathyroidism. I think it's probably worth saying that most of the time it's a condition that's caused by the removal or the damage to the parathyroid glands, which are the glands that sit behind the thyroid gland. And it's usually caused by surgical procedures that are related to the need to remove the thyroid gland usually for cancer affecting the gland itself. There are other more rare causes, including autoimmune conditions and infiltrative conditions and even genetic conditions, but most people have hypoparathyroidism for this surgical reason. It affects 80,000 people in the United States and just a little more than that in Europe. And as I'm sure all aware, for many years, the therapy that's been provided to patients with hypoparathyroidism has really been relatively simple and not terribly effective. Specifically, the provision of large doses of calcium, oral calcium supplements, and the active form of vitamin D. So we see that there's an opportunity to improve on this situation. Of course, we're not the only company that sees that things need to be improved for patients with hypoparathyroidism. And what's exciting actually is that there's been some progress in the last few years with respect to the development of other alternative treatments that don't involve just trying to replace calcium and give vitamin D supplements, but actually address the underlying cause of the problem, which is lack of parathyroid hormone. In this slide, I've identified what we call 3 therapeutic goals. The first one relates to the symptoms of the condition, which are largely caused by the difficulty in maintaining stable levels of calcium in the blood over a 24-hour period. And as I'm sure many of you are very familiar, the symptoms can be quite disabling, distressing, and debilitating. In fact, we think almost 3/4 of people with hypoparathyroidism are not terribly well controlled. Either they would say they're severely affected or they have moderate to severe symptoms. And so therefore, one of the most important goals of any new treatment would be to provide a better control or normalization of calcium levels in the blood, which would then be expected to result in better symptom control. And at the same time, eliminate the need for taking all these supplements, the calcium and vitamin D. A second therapeutic goal would be to address the longer term effects of hypoparathyroidism on the kidney, and to hopefully reverse or at least preserve kidney function, or reverse the decline in kidney function, which sometimes happens. And we observe that up to half of patients with the condition have too much calcium in the urine, because without parathyroid hormone, unfortunately, the kidney isn't able to reabsorb the calcium that is filtered from the blood, and it gets lost into the urine, where it causes some damage over many years. So one of the important goals is to decrease the amount of calcium that ends up in the urine and protect the kidneys from these complications, which include kidney stones, as well as a calcification of the kidney itself that interferes with kidney health over the long term. And then finally, the bone, which isn't something necessarily that doctors and patients think about that much with hypoparathyroidism, because part of the condition actually results in a lack of bone turnover, which increases the amount of old bone, and it results in that old bone not being turned over and replaced with new bone. And there is actually some evidence that that's not that healthy, and that in fact this old bone isn't normal in its structure. And it doesn't necessarily mean, just because there's more bone mass in hypoparathyroidism, that patients with hypoparathyroidism are at less risk of bone fracture. In fact, one of the most important things to ensure when treating people with hypoparathyroidism is that we don't make the situation worse by using a drug that would reduce bone mass, in particular because many patients who have hypoparathyroidism are peri or postmenopausal women, and that's an age group that is more vulnerable to osteoporosis or thinning of the bone and an increased risk of fractures. So it's important that whatever we do to develop a new treatment, we try to at least preserve the quality of the bone, and we don't cause any issue with bone loss over time. So one of the obvious questions, I think, is why has it taken so long for the pharmaceutical industry and the medical community generally to develop a hormone replacement for hypoparathyroidism? It's obvious in a sense that it's a disease that's caused by a lack or absence of this hormone. You would think perhaps that it would be relatively straightforward to provide the missing hormone back, rather like we do for the treatment of diabetes or the treatment of growth hormone deficiency. And there's a whole long list of other hormone diseases where they've been well treated by replacing the hormone? Well, the answer is because it's actually not that straightforward to replace the missing hormone by simply injecting a hormone replacement in this condition. And the reason is that parathyroid hormone, when it's released from the glands under normal situations, is not a very simple release profile. What we see with thyroid hormone is that there's a level of the hormone that is fairly sustained over a 24-hour period. There's a bit of variation, which we call a circadian rhythm. And then superimposed on top of that, right side of the slide, and these little pulses are of small magnitude, but they happen at high frequency. And they're important because they allow for fine control of serum calcium, or blood calcium levels. So when calcium drops or it rises, then the small pulses of parathyroid hormone that are released from the parathyroids are important for this type of control. And so if you think about developing a drug treatment for doing that, it's actually quite complicated, because on the one hand, you could introduce a drug like parathyroid hormone, which could be injected, a little bit like Natpara, which I'm sure you're familiar with, which does provide some replacement for the missing parathyroid hormone. But the problem is that it has a relatively short half-life, which means that after it's been injected and it goes into the bloodstream, it doesn't stay there for very long, which is a problem because you need not just to replace these little pulses, you need this constant level of parathyroid hormone, which should be there in the background all the time. So then logically, perhaps the next step in the development would be to come up with a drug which would allow for a continuous level of parathyroid hormone in the blood. And that's actually a drug that's under development at the moment, which you're probably all familiar with and you've probably heard about already, which is called TransCon PTH, which is based on a very innovative platform which allows for the provision of this continuous level of parathyroid hormone in the bloodstream, which undoubtedly is an improvement over the much shorter half-life Natpara situation, which doesn't really itself provide the kind of control for serum calcium that you would like to see. And Natpara undoubtedly is a step in the right direction. However, we think that that still doesn't exactly replicate the normal physiological situation, because, as I said, you have both this continuous background level of parathyroid hormone and these little pulses superimposed on top. And that's not possible to do with one drug that has this very sort of even amount of parathyroid hormone all the time in the bloodstream, which we know creates the risk that over time we may see calcium being taken out of bone and some loss of bone mass over time, which we don't want to see in people, in particular those that are more vulnerable because they have already got thinner bone because they're postmenopausal or perimenopausal women. So this is a little bit of a technical slide, but it's important because it explains the progression in thinking that led to the design of this new peptide molecule, which we call AZP-3601. And it was designed by scientists at Mass General Hospital in order to be very specific in the way that it interacts with the receptor that is the target for parathyroid hormone. And the receptor is shown on the left side of this slide in two what we call conformations, which basically means shapes. On the left side, this shape is called R0, and on the right side, which isn't in the box, the shape is called RG. And there's an important difference between these two shapes of the parathyroid hormone receptor, because in the first case, the R0 case, when a drug or the natural hormone binds to the receptor, it causes a very sustained effect in terms of the signaling that the drug is achieving or the hormone is achieving inside the cell. So to use the example of the kidney, which is one of the important places where parathyroid hormone has its activity, when parathyroid hormone binds to the receptor in this conformation, or a drug like AZP-3601 does, it causes a very long effect. So that basically means that the drug doesn't have to be itself in the bloodstream for very long. It just needs to be in the bloodstream for long enough that it can access the receptor in this conformation or this shape. And then you see a very, very prolonged effect of the drug. When the receptor is in the other conformation or shape, the RG conformation, you get a much shorter effect. And so when the receptor is in this conformation, the effect of the drug is much more dependent on how much drug you have around and for how long. So this is a more classic situation. So if you have a drug that is around for a long time, so a drug that has a very long half-life, then a lot of the molecules of the drug will bind to the receptor in the RG conformation, come off, bind again, come off, bind again. And you get this every time the drug binds, you get a signal that this goes into the cell. And once the drug is not bound to the receptor anymore, the signal stops. So if you have a drug with a short half-life, then when it's acting at the RG receptor, it has a very brief effect. And all of this may sound like a lot of detail about the parathyroid hormone receptor, but it's important because it's actually fundamental to the way that the molecule AZP-3601 was designed, because it was designed knowing that it had a very short half-life, but designed to bind to the receptor in the conformational state that would lead to a very long effect. So, of course, this all sounds very interesting in theory, but what does it mean in practice? So, as you probably be aware, drug development is a process that follows a sequence of steps. It starts in the lab with the identification of the potential drug. The drug is optimized. Scientists, chemists often play around with the drug until it's exactly doing what we think it should be doing in terms of how it interacts with its target. In this case, the target is the parathyroid hormone receptor. And then it goes through a sequence of testing in the lab before it's considered to be both safe enough as well as potentially effective to try in humans. On the left side of the slide, you see the first clinical trials that were done, which we called phase 1, divided into 2. And the two components were part A and part B. Part A, we gave the drug AZP-3601, which is an injectable, by subcutaneous injection once a day. We gave it in part 1 just a single dose. A single dose to healthy volunteers. So these weren't patients, these weren't people who had hypoparathyroidism, but these were young, healthy subjects. And the idea was to see whether a single dose of the drug was safe. And if it was safe, we would then go up to the next dose, and then the next dose, and then the next dose up, and assess a whole range of doses of the drug just given on one occasion to healthy subjects. And in part B, what we did was we took the AZP-3601 injection and we gave it multiple times at different dose levels. So we would start at the low dose and we would give it every day for 2 weeks, again to healthy volunteers. And then if that was safe and well tolerated, we then would go up to the next dose level and give it every day for 2 weeks, and assess primarily the safety and the tolerability, but also measuring the levels of the drug that were reaching the bloodstream, and also looking at the effect of the drug, because we want to see, even in healthy volunteers, whether the drug is binding to the parathyroid hormone receptor in the conformational state that it's designed to do, and whether that then leads to the effects that we're expecting to see on blood calcium levels specifically. And then on the right side of the slide, you can see the phase 2A component of the clinical trial, and we called that part C. And that was done in patients with hypoparathyroidism. We divided the hypoparathyroid patients into two separate groups, or cohorts. So first of all, we had cohort 1, and then after that was completed, we then dosed the second cohort of patients, and that was cohort 2. During the course of this phase 2A study in patients, of course, we were interested in assessing safety and tolerability, but we were also interested to see whether we could control calcium levels in the blood while removing the supplements, the calcium supplements and the active vitamin D supplements, so that in the end, the patients would end up just on the drug alone without the supplements. We wanted to see, could we do that? And could we also look at the effect of the drug on the amount of calcium in the urine? Bear in mind, that's one of the key therapeutic goals, is to reduce the amount of calcium in the urine, in particular in patients who have high levels of calcium in the urine, and also to see what would the effect of the drug on the bone in terms of some chemicals that we can measure in the blood that reflect a return of normal, healthy bone turnover or metabolism. So we measured those. And in the second cohort of patients, we also did some imaging investigations, which has used a special type of X-ray technique to look at the bone mineral density, or the amount of bone mass, that's the density of the bone that the patients had during 3 months of treatment, because this was this phase 2A study was a 3-month treatment period with the drug. So I just want to show you the results actually of both the phase 1 and the phase 2A study, because I think you'll be very interested to see that the drug is showing a lot of promise. On the left side here, you see there are 2 graphs. These 2 graphs came from the data that was generated in the part A, or the healthy volunteer study. And on the right side, these are graphs of data that came from part B, which was the multiple dosing time frame of the phase 1 study. So if we start on the left side, the left graph shows you the amount of the drug that reached the bloodstream and the concentration of the drug over time across the different dose levels that were tested. And what you can see from that is that after 2 hours, all of those different colored lines have come back down pretty much to 0, which is telling you that the amount of drug in the blood 2 hours after a single injection is almost undetectable. And that tells you that this drug, as you would expect, has a short half-life. It doesn't reside in the bloodstream for very long after you've injected it. On the other hand, when you look at the graph immediately to the right, what you see is the impact of the different doses of the drug on the levels of calcium that were measured in these healthy subjects over time. And that time period is a 24-hour time period, as you can see on the lower axis of the graph. And what you can also see is that there is a dose-dependent increase in calcium levels over time. So each one of those colored lines represents a different single dose of the drug. And starting from the bottom, which was placebo, all the way up to the highest dose, which was 120 micrograms of the drug, you can see that the calcium levels rise in a dose-dependent manner. But what's also really important to note is that the effect in terms of the persistence of the elevation in calcium levels is very long. It lasts beyond 24 hours. So there's a big difference between the time that the drug is present in the bloodstream and the effect of the drug on the calcium levels in the blood. And this is really validating the original work that was done by the chemists in the lab, where they designed the molecule to bind to that shape of conformation of the parathyroid hormone receptor we called the R0 conformation, that we expect to result in a prolonged signaling effect, which in the kidney results in a very protracted or very long effect in terms of reabsorption of calcium, which is what we wanted to see. On the right side of the graph, you can see that there is a very long effect when you give the dose of the drug once a day for 2 weeks, and stop the dosing after 14 days, you see that the calcium levels remain high for a couple of days after that. So again, showing you the difference in terms of the half-life of the drug, not around for very long, but the effect of the drug is a very protracted effect. These data that I'm going to show you now are from the phase 2A patient study. And the way that these slides are organized, on the left side is the first cohort, and on the second, on the right side is the second cohort. And what we're seeing here is the average dose of vitamin D, calcitriol, over time. And what these graphs are showing you is that by the time we got to the end of this study, and it was a 3-month study, 84 days long, the patients were able to eliminate calcitriol in all but one case. So there was only one patient who was still taking active vitamin D in either of the two cohorts. The two cohorts were slightly different from each other in the sense that the first cohort was started at a higher dose of 20 micrograms per day, and the second cohort started at a lower dose of 10 micrograms per day. But in both cases, the dose of the drug was adjusted over time so that each patient had their own individualized dose achieved, and at the same time, the supplements were withdrawn. And this is the same type of information, but instead of vitamin D, this is for oral calcium supplements. And you can see the dose coming down rapidly in both cohorts. Took a bit longer to come down in the second cohort, probably because these patients started at a lower starting dose of 10 micrograms per day. This shows you the effect of the drug on the average serum calcium level that was measured during the course of the study. The dashed orange lines show you the target range that the physicians were asked to try to keep the calcium within over time. And you can see they were successful in maintaining the average adjusted calcium levels in the blood of both cohorts of patients during the duration of the study, while they had discontinued those background supplements that I mentioned just before. This shows you the data on urinary calcium. So remember, this is an extremely important goal for the study, to get the patients off the calcium supplements and to reduce the amount of calcium that's being excreted in the urine. And you can see from baseline to day 14, there is a rapid decrease in the calcium content in the urine in both cohort 1 and cohort 2 patients. The results are actually almost identical, very similar. And the average amount of calcium that's in the urine in these two cohorts of patients was well below the upper limit of normal by the time we get to day 28 and beyond. So that's a very encouraging effect. That's exactly what we expected to see based on the design, the pharmacology of the molecule AZP-3601. This shows you what happened for each individual patient. So each dot here is an individual patient in cohort 1 on the left and cohort 2 on the right. And it shows you the line between the dots is showing you what happened to the urinary calcium content from the baseline before the drug was started until the end of the study. And you can see this is just, these are just the patients who started the study with abnormally high calcium levels in the urine. And those are, of course, the patients that we're worried about most, because those are the patients that are at risk of having kidney disease over many years. So to get the calcium levels down in the urine as quickly and as completely as this is a very encouraging observation. There is one patient out of the 14 that wasn't able to normalize his urinary calcium levels during the study. This was also the same patient that was still on the calcium and the vitamin D supplements at the end of the 3-month period. We think with more time and with further dose adjustment, and it would have been possible to withdraw the supplements, and we probably might have seen that his urinary calcium will have normalized as well. Bone safety is important. These are the data on the biomarkers that are released into the blood that reflect the metabolism that's going on in the bone. And in hypoparathyroidism, the metabolism is abnormally slow. The bone is almost in a frozen state. What you can see here is that 2 weeks after starting the dose of AZP-3601 in both cohorts, cohort 1 on the left again and cohort 2 on the right, you see a rise in both biomarkers, CTX and P1NP. CTX is the marker that reflects the breakdown of bone, and P1NP is the marker that reflects the formation of bone. And what you want to see is that both of these biomarkers are going up, but they're not going up very high, that they're going up in a balanced fashion, so that you're seeing turnover, but you're not seeing net loss of bone or even net creation of bone, because that's not the goal of treatment here. And that's exactly what the biomarkers suggest from the data we have. I mentioned at the beginning, in cohort 2, the second cohort of patients, we also took special x-rays of the bone, a technique called DEXA, which allows us to assess the density of the bone, as well as the quality. So on the left side is the density, and on the right side is the trabecular bone score, which is a special way of analyzing the images in the spine to give us an idea about the quality of the bone. The gray bars are the baseline before treatment was started, and the orange bars are at day 84 at the end of the study in both cohorts. And here you can see there's really very little, if any, change at all in either the bone mineral density or the bone quality during the course of treatment. And this is another way of looking at these numbers. Here, what we're doing is we're taking those bone mineral density scores for each patient, and we're putting them into the context of a population of people. On the left side, the population is an age and gender matched population. So it's as if you're comparing the bone density score for an individual with a group of similar age and the same gender, but without the condition, without the disease, to see how that looks. On the right side, you're doing the same thing, but you're comparing the bone density score with a population of young, healthy people. So the right side is really more of an accurate reflection of the risk that is represented by the bone mineral density relative to a young, healthy population. You can see that it gives you a different picture. In both cases, looking at the light and the dark gray, you can see very little change between baseline and end of treatment in the patients in cohort 2 who were treated with AZP-3601. Importantly, though, when we looked at the so-called T-scores for the patients, almost half of them had what we call osteopenia, or a thinning of the bone, which was represented by a T-score that was at least more than a score of -1 from underneath the 0 mark. And this osteopenia is obviously evidence that there has been some bone loss, probably in some of these patients in relation to advancing age and also peri or postmenopausal status in the female patients. So it just underlines the fact that we really do want to try to take care of bone health in patients with hypoparathyroidism, and we can't assume that just because they have patients who don't have the parathyroid hormone activity, just because their bone mineral density is a bit higher than normal, that they somehow are not vulnerable to a risk of fracture in the future. So these are the conclusions that I think are important based on all of the data I presented. First of all, the safety profile of 3601 was very reassuring. The drug was well tolerated. We didn't see any serious adverse events in any of the patients, or in fact adverse events that were severe in intensity. All of the so-called adverse events were mild or moderate, and there were no adverse events that led to patients discontinuing the drug and stopping the study. In addition, as I showed you, treatment with the drug was successful in controlling the the calcium levels in the blood, while being able to withdraw the vitamin D and the oral calcium supplements. We also saw a rapid and profound drop in urinary calcium content that normalized the calcium content in the urine for almost all of the patients with elevated calcium at baseline. And we also saw some reassuring information from the bone biomarkers that reflect bone metabolism, as well as the X-rays that were done to assess bone mineral density over time. So the next steps, we need to take all of the data that we've generated on the drug up to this point and go and meet with the FDA and have a discussion with them about our plans for our phase 3 clinical trial. We benefit from the fact that we're not the first company that's developing a drug in this indication for patients with hypoparathyroidism. And so we have an idea about what the agency is thinking in terms of the kinds of evidence that they want us to generate that would satisfy them so that they would be willing to approve the drug for use for patients in the future. We expect to have that conversation with the FDA very early in 2023. And following that conversation, we'll finalize the design of the study, and then we'll be implementing this study in patients we hope within the first half of 2023. So we're obviously very excited, and we're looking forward to doing that, because we really do think that we have an innovative new peptide molecule that's been specifically designed to address the key goals of treatment for patients with hypoparathyroidism. I think that's my last slide. It is. So I will stop there, and happy to take questions.
All righty. Well, thank you so much. Let me grab a few questions for you. All right. So how long would it take for the lack of bone turnover to show to make an impact?
So the lack of bone turnover is really the current situation for people who have hypoparathyroidism. I think what the question the questioner is asking is, how long would we have to treat patients with this new peptide molecule before we can see whether we're having a sort of a good effect, or we're not causing a problem with the bone? Because that's really the goal. As I mentioned, what we don't want to do is what we call demineralize the bone, take calcium out of the bone, take structure or bone mass away, and then leave people at an increased risk of having a fracture because their bone is not of normal strength. That's a really good question. I think that was what the questioner was asking. I think the short answer to that one is you get an indication probably within 6 months to a year, but you have to follow people for longer than that before you really see ultimately where things are likely to stabilize. So we don't yet know with certainty exactly what the impact of AZP-3601 will be, but based on what we see so far and based on the pharmacology of the peptide, we actually don't expect it to have any real effect on the bone, which is actually what we're looking for. We're looking for stability. This isn't a drug to treat osteoporosis, but it's a drug to treat hypoparathyroidism, where we want to protect the bone and make sure that it doesn't get more brittle or more structurally unstable over time. So several years is probably the answer.
Okay. And did the phase 2A include a control?
No, it didn't. So it was what we would call an open label study. So all of the patients in the study received the drug. Having said that, the next step, which is the phase 3 study, will include a control group. So in that study, rather like the TransCon PTH phase 3 study, which I'm sure people are familiar with, we would randomize people either to the drug or to a placebo, and you won't know which you're going to get ahead of time. And we will follow people for 6 months while they're on treatment and look to see how well the patients do who are on the drug in terms of ability to come off the supplements and maintain good control of serum calcium. And we'll be interested to see the impact of the drug on urinary calcium and symptoms and all of those important things, as well as the bone safety.
Okay. And in phase 2A part C, what was the impact on participants regarding brain fog, cognitive functioning on the participants, and how did you measure these outcomes?
Yeah, so we did implement a questionnaire called Short Form 36, SF-36, which you may be familiar with. The disadvantage of that is that it's not designed specifically for people with hypoparathyroidism. It's actually used in many different situations to assess how people are feeling and how they're functioning. And so it gives you an indication, but the really sort of important test actually is based on what we call patient-reported outcome questionnaires that are specifically designed for this condition. And that's something that we're going to do when we do the phase 3 study. Having said that, we did look at the SF-36 questionnaire, which assesses physical functioning as well as cognitive or mental functioning. The results are currently being analyzed. I'll say that preliminarily anyway, it looks like there's some encouraging signs, but it was a short study, so it was only 3 months. So in the next study to come, we'll have a more definitive data.
Great, great. So what is a specific timeline to get it to the FDA for approval, and how long will the phase 3 be before submission?
So we plan to start the phase 3 study, as I mentioned, hopefully in the first half of next year. It'll probably take us about 8 months or so to enroll the study. It'll probably have 150 to 160 patients in the study, so it's a relatively large study actually. And then we need a period of time for when the last patient is enrolled, for that patient to get to the end of the 6-month double-blind placebo-controlled period. So with all of that said, in terms of dates, we expect that we'll be finished with the study and we'll have the data that we would be able to submit to the FDA sometime probably early 2025, and then hopefully an approval which would be maybe 9 months to a year after that, so 2026.
Okay, and how would one participate in the phase 3 study?
So we're in the process of contacting all sorts of centers around the world. We are going to include centers in North America, so the US and Canada, and also Europe. That will be probably the limit in terms of the geographic areas that we'll include. We will contact specialist centers, endocrinologists who have experience enrolling patients in clinical studies. We're in the process of collecting all the information from those centers at the moment to establish whether they have patients that they think would be eligible, they have the experience, the expertise, the capacity, et cetera, to participate. So once we've done that, we'll have identified the patients for participation, the centers for participation in the study. At that point, if a patient is interested but hasn't been approached, hasn't heard from their physician about the study, it's always possible for somebody who's interested to contact their endocrinologists and ask if they're aware, and ask them to put either their endocrinologist or maybe a colleague that is known to that endocrinologist in touch with the company. And then we can deal with potential to include the patient through either the center if it's already participating, or if there's a way of referring the patient to a participating center, the person to a participating center, then that's also possible. So it goes through the treating physician.
Gotcha. All right. So if it doesn't treat osteoporosis, might it arrest the progression of it?
Well, as I said, we're hopeful that it's going to have a pretty neutral effect on bone. So physicians, I think, if patients are developing osteoporosis and they're monitoring patients for osteoporosis, they'll, in a sense, they have to think about that separately. And at some point in the future, there's all sorts of interesting questions that could be asked about whether or not an osteoporosis drug might work in combination. But this drug, to be really clear, is not a drug that is designed to treat osteoporosis. We expect it won't have much impact on the bone, and that's actually what we're trying to achieve here. We're trying to address hypoparathyroidism without causing bone loss and making that situation worse for people.
Okay. And will prior PTH therapy or kidney function be exclusionary?
No. So not well, I say no. The short answer is no. And actually, as far as the kidney function is concerned, we will probably allow, unless it's very severe kidney dysfunction, we will allow patients who have impaired kidney function. And actually, we want some of those patients to participate in the study. As far as prior PTH analog therapy is concerned, as long as it isn't recent, so probably would have a 3-month washout period. So if it's currently the case, then the patient would have to stop it for a period of time before they would be able to be screened for being included in the study. So there is a possibility. And obviously, if somebody's had it longer ago in the past, then clearly it's not a problem.
Okay. And then somebody had asked, how do you safely do a placebo for someone with hypopara if you're removing calcium and active vitamin D?
That's a good question. You have to do it very carefully. So in the protocol, and of course, as you probably know, it has been done, and it has been done carefully and safely with recent studies. You have to make sure that the physician is at least early on frequently measuring serum calcium levels. So as the drug is started, or the placebo in this case is started, then clearly as patients are withdrawn from their background therapy, if they're on placebo, the calcium will start to fall. The physician has to be monitoring calcium often enough that they will see that starting to happen. And once it gets to a certain point, the patient will be restarted on background therapy. So they won't be allowed to drop their calcium level to a level that's concerning.
Okay. And then as more and more patients get older, why are the older patients not allowed in the trials?
Oh, they are.
Okay. Very good.
So, to be honest with you, I actually don't know if we have specified yet any cutoff in terms of upper age for participation in the study. One has to bear in mind that that at a certain point, unfortunately, we all get to a point in life when we're that old that we have other conditions and other issues, and those things can sometimes become problems if you want to participate in a clinical study. But really, for somebody who is just simply older and is generally otherwise healthy, but obviously has hypoparathyroidism, I don't see any reason why they can't participate.
Okay, very good. Let's see, let me go back to this question. The phase 1 and 2 use calcium levels of only 8.0 to 9.0. That is very low for hypopara patients from this patient who wrote this. Most want to be between 9 and 10. Can this be achieved without supplementation?
Yeah, so what we're going to do in the study is there's a normal range for calcium, and then there's in the study what we're calling a sort of therapeutic range or a target range. And this is within the normal range, and there's obviously a sort of, by definition, a range, so that there's space within it, so that you don't have to keep adjusting the dose of the drug, because the calcium doesn't stay exactly flat. As long as it stays within the range, that's just fine. Different patients tend to have slightly different thresholds above which or below which they may start to feel symptoms, because we all probably had a calcium level in our blood that we got used to before we had hypoparathyroidism if we're a patient. So what you're trying to do is sort of get the calcium level back to what it was for that individual patient, that is, if you like, the level for them. And it's actually quite difficult to say there's one range that suits everybody. Generally speaking, physicians at the moment with standard care with calcium and vitamin D tend to try to run the calcium level at the lower end of the normal range. And the reason for that is purely because it's usually adequate to avoid symptoms, and it also minimizes the amount of calcium that ends up in the urine, because the higher the calcium level in the blood, the more calcium leaks into the urine and the more problems that can create later on. This is different now, because if we're using a drug that's actually a parathyroid hormone acting drug, we won't see that calcium leaking into the urine. We can run the calcium levels higher without worrying about the calcium entering the urine and causing problems. So we're going to move the range up in the phase 3 study now that we've demonstrated that the calcium actually isn't spilling into the urine. It's normalized with the drug. And we will actually have a range in the mid-normal range for calcium, which would include the numbers that the person who asked the question asked.
Okay, and then somebody had asked, will phase 3 be double blind?
Yes, in theory. The reality, of course, is that, you know, when a patient is randomized to placebo, even though at the beginning it's double blind, which means that neither the patient nor the physician know whether the patient is getting the drug or placebo, it's likely that it'll become very obvious fairly quickly, because those that are being randomized to placebo will the vast majority of them will be unable to come off the supplements. So it's kind of a bit of an unavoidable unblinding, if you like, but it's really the only way to design the study.
Okay, and then will the Hypopara patient experience scale be used in phase 3?
So no, it's the short answer. The company has to design the what we might call the patient-reported outcomes questionnaires in a way that the FDA finds meets their requirements and their standards. And so rather like has been done in the past recently, done by Ascendis for TransCon PTH in their study, Amolyt has to do the same thing. So we will have these patient-reported outcome questionnaires that we've created specifically, will be very similar actually to the ones that have been used recently for TransCon PTH, but have been tested in the right way and validated during the course of the study in a way that the FDA will find is valid and that they will accept that the data accurately reflect improvements either in symptoms or symptomatic scores or cognitive scores, which are the domain scores that we're interested in. So unfortunately we can't, we will use SF-36, but we can't add more and more because it becomes very burdensome for patients actually to be filling out all these questionnaires. And we realize that one of the things we need to try to do is make the experience of participating in the clinical study not too burdensome so that people get fed up and they want to withdraw.
Yeah. Okay, and then let's see, were the patients off calcium entirely? Don't patients still want to be on some calcium because you need it for general health, especially
Yes.
for those who don't eat dairy?
Another good question, and the answer is yes. The person that asked the question is absolutely right. So what we did is we defined a threshold for oral calcium supplements, that anything that it was less than 500 milligrams of calcium per day in supplements was considered to be calcium that is simply supplementing the diet, that is calcium that you want to take. Anything above 500 milligrams a day was considered to be therapeutic. In other words, being used to specifically address the problem in hypoparathyroidism of maintaining calcium levels in the blood. So anything under that 500 wasn't counted as actual therapeutic calcium supplements. So when I said when I presented the data that they were off their calcium supplements, what I should have said is that they were taking doses of calcium that were less than 500 milligrams per day. And of course, they're getting other sources of calcium in their diet as well, and it is important.
Okay. Let's see. So we have a couple of other questions. So from your opinion, is there a better way for people to explain their symptoms. An example is somebody had severe hip pain, but it was really related to low vitamin D. So what would be your advice from your perspective for that question?
Yeah, so when a patient is participating in a clinical trial, what we would expect and what we would hope is that we collect the patient's experience. So in the case of the example here, the patient's experience is hip pain, and that's exactly what we would want to be reported. Because in the context of a clinical study, we want to be completely unbiased about what might be the underlying reason for the hip pain. Now, of course, we're also collecting lots of other information about every patient. And during the course of looking at all of these events, which could be hip pain, headache, nausea, all sorts of things get reported. We want to see, does it happen more often on the drug versus the placebo? And if it did, was there an explanation, likely explanation, that wasn't the drug itself, but might have been related to the condition or the disease, or in this case, a low level of vitamin D or something else. We always look for that, to look at what we call causality, because we want to know, is this a drug effect or is it just part of the condition? But from the patient's point of view, we just want to know, what are you experiencing? We don't want you to try and diagnose what's causing it.
Yeah. Okay. And then how can we get other doctors invested in learning about the symptoms?
That's a good question. So it's actually one of the opportunities that I think is a responsibility of companies like Amolyt and other companies that are developing drugs for these kinds of conditions. It's also one of the things that we can do when we partner with patient associations like the Hypoparathyroidism Association. It's education, not just of patients, but also physicians. So what tends to happen is that, assuming that things go well, and the company progresses the drug, so the company begins to form more and more relationships and associations with endocrinologists that are managing or treating the condition, and it's sort of word goes around. The company will facilitate educational events, symposia, direct interactions to some extent with scientists at the company and physicians who work in the company. Some social media opportunities as well for education and interaction with physicians. So there's lots of different ways of education, and it's not, and the company has a responsibility to support that. And hopefully we can partner with the Hypopara Association to achieve it as well.
Absolutely. You can count on us for sure. All righty. I think that is it for questions from our perspective. Anything else you want to share before we let you go today?
No, I think I just summarized by saying thank you for the opportunity, and it's a pleasure to have had the chance to talk to you about the new product.
All right. Well, thank you very much for helping us today. All the information that you shared, it's been fantastic.